Good evening, everyone. This is Frederick Zero from OCULUS, and this evening we have the opportunity to have Dr. Duchesne from hospital in Liège, Belgium. Thank you for being with us, Dr. Duchesne. Can you please introduce yourself?
Thank you, Frederick, for the invitation. My name is Bernard Duchesne. I'm associate professor in the Department of Ophthalmology at the University of Liège in Belgium. I've made a research fellowship at the Bascom Palmer Eye Institute in Miami in 95-96 with Jean-Marie Perel, who just passed away a few weeks ago. And since then, I'm running a very smart and efficient corneal team with Sandrine Hick, Céline La, Claire Tilquin, and soon Alexandra Radermacher. And also we have a very efficient eye bank in Liège.
Okay, thank you, Bernard. Bernard, obviously you tried the new Pentacam Cornea OCT at your hospital for a few weeks.
Yes, and I was very lucky to have it for a few weeks. Yeah.
Yeah, you were amongst the few, the first doctors in the world to have it, and we are grateful for your feedback on this. So, but I wanted to ask you, what motivated you to start testing this new instrument in your department?
Well, actually, I'm always interested in the new development in corneal imaging, and the swept source OCT, spectral domain OCT are new tools that brings us to the next level of corneal imaging. And as you probably know, there is no more confocal microscope available on the market. And so it means you better hurry to discover the way to replace it in the future.
Okay. What, in simple terms, what were your first impressions when you started using this device compared to what you had before?
To be honest, my very first impression was that we can expect much more from that machine. It would be much better in the future, I think, because it seems to me that we can have greater view, deeper view, and even more detailed view in the future. But then, by using it, and over time, I realized that it was already amazing to be able to differentiate in vivo at a cells level with an impressive magnification in a minute. It's so impressive to be able to see even details like 1.9 micrometers, which is something amazing, and I still cannot realize the size of what I can see with this machine.
Okay. I mean, without getting into the nitty-gritty technical details, how does it differ from other machines?
Well, obviously, there is a much higher precision with this machine compared to the other. And actually, it's the beginning of a new way to analyze the cornea. So I don't even have enough experience yet to understand every image I have seen so far. But I think the best way, let's take a look to some example we took within the clinic.
Okay, there you go.
Here we go. As you can see, this is the first patient we got with Acanthamoeba keratitis due to ortho-K, which is the lens that the patient has to wear during at night. And if you take a close look to the next picture, at a higher magnification, you can see the Bowman's layer like never before. You can see the layer, the collagen layer into the cornea. And that's the first time we're able to see at this level. The precision of this image is amazing. You can go to the next one. Another example of a 12-year-old little girl who used color contact lens just for fun, and she got an Acanthamoeba keratitis on both eyes. And if you look to this picture, the scar tissue seems to be hold the thickness of the cornea. And if you look to the next one, you can see clearly that behind the scar tissue, there is still some clear cornea underneath, which means that the surgery can be done with a lamellar graft in this situation instead of a penetrating graft, which is impossible to do right now because she is only 12 years old. But in the future, we will be able probably to do a lamellar graft in this situation. With the previous machine, it was impossible to differentiate the scar tissue to the normal tissue that you can see here. Next. Here, if you have a general overview of a flap trauma post-LASIK surgery, you cannot explain to the patient why the vision is so bad. But if you go deeper with a higher magnification, next slide, you can realize that the folds into the flap trauma explain perfectly the aberrometry of this eye and explain also the very bad vision that the patient has with this LASIK flap completely folded. Next one. Here, it's a Salzmann degeneration. It's a patient who came to me to remove the Salzmann nodular underneath the epithelium. But by doing this exam, we realized that there is something wrong also in the back part of the cornea, and it was impossible to see it with another exam. If you can pass the next slide, you can see clearly in the back part of the eye this lesion. I don't even know what it is actually, and so we will have to follow this patient with this machine to see if it's an ongoing situation or if it's stable. We don't know yet. Next one. This one is a very interesting patient. He came to me 24 years ago, 24 years old, and he came to me for what was supposed to be a scar on a keratoconus. He saw several ophthalmologists, and everybody was saying it's scar tissue in a keratoconus. And actually, the patient came to me with the diagnosis. He told me, okay, since I'm a little boy, I've been operated for a ptosis, and since then I have an exposure keratitis. And so I realized that it was not a scar tissue in a keratoconus. There is no keratoconus at all. And by seeing this image, you can see clearly the delamination between the epithelium and the stroma, which is completely normal. And we decide with the patient to do an epikeratectomy to remove that lesion. And if you can pass the next one, you will see in the follow-up after the surgery, there is no more scar. The cornea shape is perfect. And with the contact lens, the patient has no photophobia, and the vision improved tremendously in this patient. So with this machine, I've been able to show to the patient what I will do as a surgeon, and the expected aspect of the cornea is perfect now. So I'm very happy, and the patient too.
Okay.
Next one. This is a patient who went for a laser surgery for pneumos following adenoviral keratitis. And the patient was expected better vision after the laser surgery. And he came to me. I didn't do the laser. It has been done somewhere else. And the patient came to me because the vision didn't improve anything. So by using this machine, you can see clearly that the pneumos are deeper into the cornea, and that explains that the laser didn't clean the pneumos into that cornea, and so the vision was not improved at all by doing the laser. We were expecting well, we don't know yet what to do with this patient. Probably we have to wait a little bit more, because I think the laser was done too early after the onset of the infection. But we will see in the long run what will be the future of this cornea. Next one. This is also Salzmann degeneration. That's very easy to explain to the resident, to the fellow, where we have to put the knife to be able to remove the Salzmann degeneration. You can see clearly underneath the Salzmann nodules, the layer where you can expect a very easy way to peel the Salzmann nodule. So it's very easy to explain to the patient, to explain to the resident what will be the surgical plan. Next slide. Here you can explain to the patient why the vision is so bad after a radial keratotomy. As you can see in the right part of the cornea, there is a corneal epithelium invasion into the radial keratotomy. And this can explain the increase of astigmatism and also the opening of the corneal incision, which is always fluo positive due to the corneal invasion. And you can see clearly the invasion of the epithelium. Next. Here you have a DMEK detachment. You have a fold into the Descemet membrane. It's very easy to understand and to, well, we can see with some other machine, but in this case, it was very nice to explain to the patient why we had to replace a bubble into the eye to make sure that the DMEK is correctly attached afterwards. Next one.
Dr. Duchesne, I wanted to ask you, do you see this machine as a benefit also for the patient itself, for education, right?
Yes, obviously, it's so easy to explain and to show to the patient what was the problem, but also in the clinics. I'm here at the university, so we have to teach our resident, our fellow, in cornea, and this is a very nice tool to explain. It's so the magnification is so nice. I forgot to mention that there is a special way to analyze, which is called the zoom technique with the Pentacam Cornea OCT, and that's the way to increase the magnification and to see the details like never before.
Okay.
The next one, it's only to show you the Salzmann. Oh yeah, in this situation, it was a little bit difficult because this patient has been operated a long time ago for a Salzmann degeneration, and the patient seems to have some difficulties with the vision. The astigmatism is increasing. And as you can see here, you can see some fibrotic tissue at the place of the Salzmann degeneration. But if you take another exam with the Pentacam, next one, you can see clearly here that it's a recurrency. It's not a fibrotic tissue. It's actually a recurrency of the Salzmann degeneration. And so we have to do a new surgery, which will be a little bit more difficult because there is some fibrosis underneath the nodules. And so the removal will be a little bit more difficult in this situation. Next one. Here is just an image of a CHED, a congenital hereditary endothelial dystrophy, and we have to understand a little bit better in the future what we are able to see, because there is something here which is abnormal in the epithelium. The thickness obviously is very, very it's huge thickness, but we don't know yet what we are able to see. So we have to learn over time with this machine.
Okay.
Next one. Yeah, this one is just to see a scar formation after a very bad infection and a corneal thinning. It was not easy to see under the slit lamp, but with this machine, we can see clearly the thinning. The next one. Here, I've been able to explain to the patient that the calcium deposits was too deep to be operated. And if we remove the calcium, we will remove half part of the cornea. So it was impossible to remove the whole calcium deposit. And it was easy to explain to the patient by using this image to explain how deep was the calcium deposits. The next one. Yeah, I'd like to thank Oculus and Simovision for the opportunity to be able to see and to be lucky to see all those pictures. It was very nice. I hope I will be able to get this machine in the future.
Sure. Thank you, Dr. Duchesne. I wanted to ask you to finish on this. Do you see this kind of technology as a game changer for future research? And additionally, are there any, I'm playing the devil's advocate here, would you like to see additional features?
Yeah, a long time ago, someone said, I have a dream. And I'd like to say that I have a dream also, to be able to one day to compare the histology of corneal pathologies with the image from the Pentacam Cornea OCT. I think it will be a very nice book for the cornea to compare histology. And also, I think this will be very efficient to better understand the cicatrization process. We will be able to image an ongoing cicatrization within the epithelium, within the stroma. And so with the future development of this machine, probably we will be able to observe the cicatrization ongoing. This will be wonderful for the future.
Okay, we'll try to bring that in the future. Okay, Dr. Duchesne, thank you very, very much for your time tonight, and we hope to see you again soon in the future. Thank you.
Thank you very much.